Thank you for the kind introduction. Now, we all know mechanical ventilation, the common modes that we use, that is the CMV, assist control, SIMV, pressure support, etc. But now we know that there are patients who are difficult to ventilate and difficult to wean as well. So there are now advanced modes or intelligent modes which have come up, which can, excuse me, just give me a minute, sorry. So sorry, this was just a simulator which I was trying out for today's lecture. So sorry for the interruption. Yeah. So the thing is that these things have now come up, the new advanced modes and the new modes have come up, which have a mind of their own. And it is not what the operator has said, but they can gather feedback from what the patient situation is, the lung compliance, resistance, saturation, EtCO2, and can apply all those knowledge and guide the operator, or in fact, even take over the ventilation themselves so as within the set targets. So that is now the advent of AI in the realm of mechanical ventilation. At the outset, I like to say that I've got no financial obligations either with Learnet or the companies that I'll be taking the names of, and I do not endorse any particular company or manufacturer or any type of ventilator. Now, as I said that
Sir,
the
sorry
new
to
ventilators,
interrupt.
yeah,
Sir, sorry to interrupt. Dr. Nitin Haran sir has
yeah,
joined us. Good evening, sir. Welcome to Clarnet session, sir.
Welcome, madam.
Good evening, sir. How
Good
are you
evening,
doing,
good
sir?
evening, ma'am. Good evening.
How are you doing, sir?
Okay, I'm fine, good.
Okay, sir, as you can see, Professor Nishant Kumar sir has already started with his lecture. So after his lecture, I'll introduce you and your topic, and I'll hand over the session to you. After the session, we'll address the question what we have received from the participating doctors. Is that okay, sir?
Okay, okay.
good
All
evening,
right.
Dr. Nitin, welcome.
Good evening, Dr. Nishan.
Thank you, Dr. Kumar. Sorry to interrupt you.
No,
Please
no
proceed
issue,
with
no
your
issue.
talk, sir.
Yeah, thank you.
Thank you, Dr. Haran, sir.
Okay. So yeah, so what we were talking about is the feedback from the patient. So what the neuro modes do, they are sort of a closed loop. That means that they take a feedback from the patient and guide the operator or make the adjustments themselves so as to give the best possible ventilation strategy for the patient, for the lung that is diseased, for the airways, and overall. So we know that there are these certain modes which are there. That is, now don't go by the nomenclature because each manufacturer will have its own nomenclature. So try and understand what the mode does. So the most common one is PRVC, pressure regulated volume control, otherwise also known as VTPC, PCVG, APC, MV. So depending on the manufacturer. So this is the second one is BiPAP. Now BiPAP is biphasic positive airway pressure or bi-level positive airway pressure. So now these are two different modes, bi-level positive airway pressure and biphasic positive airway pressure. Both are written as BiPAP, but then it is a bi-level which we'll be talking about. And this is an invasive mode, whereas biphasic positive airway pressure is an NIV mode. And then we have the APRV, that is the airway pressure release ventilation. Then we have the adaptive support ventilation, the IntelliVent, volume support. Now, till the IntelliVent, now these are the modes which can be used for controlled ventilation as well. Whereas the volume support, proportional assist ventilation, that is PAV, NAVA, neurally adjusted ventilator assist, and SmartCare pressure support. These are mainly used for smart weaning. And then there's the CPRV, that is the CPR volume control mode, that is used during cardiac arrest and CPR. So coming to the first mode, that is pressure regulated volume control. Now pressure regulated volume control is also known as APC, APV, VTPC, PCVG, depending on the manufacturer. Now remember, it is a dual mode. The delivered breath, the type that is delivered is a pressure controlled breath, although it says pressure regulated volume control, it is a misnomer. The correct terminology for this mode is either a VTPC, that is volume targeted pressure control, or pressure control volume guaranteed, which describes it the best. How? We'll see it later. We'll just see in a minute. Now, this is the mode which is in the Hamilton ventilator. It is APB CMV or APB SIMV. Now, this mode can be used both in paralyzed patients as well as in patients having spontaneous breaths, that is either in this CMV controlled mechanical ventilation mode or the SIMV synchronized intermittent mechanical ventilation mode. So as I said, it is a dual mode. That means that it incorporates the features of both pressure control as well as volume control. How? So the advantages is that although the pressure control, the breath that is delivered is pressure controlled, that means that a peak inspiratory pressure is delivered, the volume is ensured. Now we know the drawback of pressure control, that is that with the changing compliance and resistance of the airways in the lungs, the volume is not ensured and the volume changes breath to breath. However, in this, it is, what do? We set an FiO2, we set a set rate, we set PEEP, and we set a tidal volume. So here, if you see these settings, we have the FiO2, the PEEP, the tidal volume, and the rate, which are set as a primary setting. So what it does is that it gives a test volume breath to ascertain the peak pressure and lung compliance, that is the resistance and compliance of the lungs, right? So it delivers a pressure control breath at a particular pressure, sees what is the expired tidal volume, and then adjust the pressure till that particular tidal volume that you have achieved is delivered. Now, the safeguard for the barotrauma is that you set the alarm limit. So, same as in volume control, if you have set the pressure alarm limit as say high peak inspiratory pressure as 40. Now, although you might have set a tidal volume of 500, if the pressure reaches 40, that means that the inspiration will be cut off and no further breath will be delivered, no further tidal volume will be delivered. So it is basically, it behaves like a volume control. The settings are like volume control, but the breath that is delivered is pressure control. So the advantage of this mode is that we all know that pressure control gives the maximum tidal volume with the least pressure. So that is the advantage. Another advantage is that you can actually come down on the IE ratio. So in volume control, it is important to keep the IE ratio as 1:2 or 1:1.7 or 1.8 for complete exhalation. But here you can actually go up to 1:1 ratio or even inverse ratio in this mode. So that is the advantages. And because of the feedback mechanism, it gives the lowest pressure to achieve the maximum volume. So that is the advantage of PRVC over other modes, and it is really helpful in stiff lungs and in airway resistance, wherein it combines both the advantages of pressure control and volume control ventilation. Right? Okay. So the second one is biphasic positive airway pressure. As I said, bilevel, not to be confused by biphasic. I confused it myself. So the biphasic positive airway pressure is the one which is used for invasive ventilation, and BiPAP, the one with a small I, is the bilevel positive airway pressure. So biphasic positive airway pressure, it is a combination mode of pressure control plus spontaneous mode. Now, what is the difference between the small I and the big I? So what is the difference between biphasic and BiPAP? Now, the basic difference between biphasic and BiPAP is, bilevel is that bilevel more or less behaves like a pressure support. That means that you set an IPAP and you set an EPAP. So you set the pressure support, and BiPAP, the bilevel is only for spontaneously breathing patients, whereas the biphasic can be for controlled as well as the spontaneously breathing patients. Now, as I said, it is a combination of pressure control and spontaneous respiration. So it is pressure controlled, time cycled, and normal I ratio. What you do is, what is the difference? That you set two PEEP levels, a PEEP high, you set a PEEP high and a PEEP low. So that means that during some period, the breaths are delivered at a high PEEP, and then some breaths are delivered at low PEEP. Now this can be used for spontaneous mode also. Similarly, you set two time settings, a T high and a T low. That means T high means the time for which the high PEEP remains active, and T low, the time for which the T low remains active. Now, expiration valve is active throughout the phase. So if the patient wants to breathe spontaneously and expire, patient can do so. Okay. So basically what happens is that for a spontaneously breathing patient, the PEEP for this period of time is 15. So the patient takes spontaneous breath at 15 PEEP. Then suddenly the PEEP is reduced and the patient breathes at 5 centimeters of water PEEP. So that means that there's recruitment, and then as you all know that high PEEP may cause discomfort. So there is a periodic release of PEEP so that the patient synchrony and patient comfort is maintained. It is very useful to wean off patients with COPD and airway disease. A similar mode, very similar to airway pressure, to biphasic positive airway pressure, is airway pressure release ventilation, that is APRV. More or less, it is same as BiPAP. Again, it's the combination of pressure control and spontaneous. The rate is set by T high. Now you do not set the rate in this. We'll just come to the settings in the next few slides. So you do not set the rate on your own. What you set is the T high and T low. And again, you set the two PEEP levels, that is PEEP high and PEEP low. Expiration valve is active. And as compared to the BiPAP, more time is spent on T high. That means that the patient keeps on breathing at T high. Again, usually this is used in the spontaneous mode only, not as a control mode. And this mode has specifically proven beneficial for oxygenation in severe ARDS. And more time is spent on T high. So that means that patient is continuously breathing spontaneously at a high PEEP level, and then suddenly there's a release or the PEEP drops to 0 or very low, so that the accumulated CO2 can be released out, and it is for a very short period. So mainly the patient keeps on breathing at T high so that the de-recruitment of the alveoli doesn't occur. Now, if you see these two settings, on the left of your screen is the BiPAP, and on the right of your screen is the APRV. Now, if you see that in APRV, as I said, what you set is FiO2, then we set the P low, that is P low, P high, T low, and T high, and the RAM. How much is the rise time and the flow trigger? In the BiPAP, what we set is oxygen, FiO2. Again, we set the PEEP, that is P low. We set the P high. Here we are setting the rate. If any rate controlled breaths have to be given, that is set, and T high is set. Okay. So T low is dependent on the rate that is there. So 0.8 seconds of the total inspiratory cycle will be T high, rest would be T low. We set the P RAM, and we set a separate pressure support for spontaneous breaths. However, in this, what we do is we only set a T high and a T low, and the rate will depend on the ratio of the T high and T low. How? Now, these are the graphs in APRV and BiPAP. So if you see in APRV, this is P high and T high, and there's a sudden release. So if you see this part only, this small part is the P low and T low, right? This is the pressure graph, this is the volume graph, and the spontaneous breaths can occur at any point inside the cycle, right? So the rate will depend on the ratio of T highs to T low, and that is how, and if the patient wants to take spontaneous breaths, patient can occur at any point without altering the ventilator delivered breaths. Whereas in biphasic positive airway pressure, if you see, you have the P high and T high, and you have the P low and the T low. And again, the breaths can occur at any time, and this can be used for a purely spontaneous mode. Both of them, in fact, can be used as purely spontaneous modes, but here there will be some breaths which will be delivered that is based on the T highest to T low ratio. Now, what are the indications for APRV? As I said, for biphasic, it is mainly the obstructive diseases and weaning that we use. And for APRV, patients who are recruitable, that is must. That means that you have to first check whether you can recruit the alveoli or not. Patients with diffuse processes, that is multifocal pneumonia, ARDS, you cannot prone the patient, or those who have not responded to prone position. Patients who have high risk of respiratory deterioration, that is traumatic chest injury, aspiration, inhalation injury, and ARDS. Patients with sepsis and multi-organ failure, obese patients, and where the low tidal volume ARDS net protocol has failed. In these, APRV has shown to improve oxygenation and improvement in the status. So the contraindications: profound cardiovascular instability, specifically hypovolemia, pulmonary resection, severe bronchospasm. Now, again, this is one which cannot be used for obstructive diseases. Pulmonary hypertension with right ventricular decompensation, bronchopleural fistula, pneumothorax, and restrictive lung disease. Now, restrictive lung disease, we all know that ARDS is sort of a restrictive lung disease, but a pre-existing restrictive lung disease, it is better not to use APRV. So, how do we set APRV? First of all, we set FiO2 as 1. We set P high at whatever is the current plateau pressure of the patient. So suppose the patient is on CMV, you perform an inspiratory hold, you determine the plateau pressure, and that value is how you set as P high. P low is set as 0 initially. Now, setting up the timings. Now, setting up the timings is important. Normally, it is kept in a ratio, T high and T low are kept in a ratio of 10:1. So that means that if we set an initial T high of 5 seconds, the range is from 3 to 8 seconds. And we set the T low 1/10 of the T high, that is 0.5 seconds. Again, the range is from 0.3 to 0.8 seconds. And it is the T high which will determine the rate that is being delivered by the patient. Now, when we set these values, you look for the expiration. Now, we all know that the downward stroke is the expiration flow, the flow time graph. So this is the peak expiratory flow rate. And if we set the T low too low, and that means T low is less, that means that the expiration is terminated before 75%. So ideally, this should have terminated around here. That means that 75% of the expiration should have occurred before the next inspiration cycle occurs. So if that occurs, then you increase the T low in steps of 0.1 seconds. So that is how you do it. Okay. Because otherwise it will cause alveolar collapse and de-recruitment. So that is how you set it for controlled. These are the settings that you do for controlled ventilation. Now, APRV can also be used for weaning. So APRV for weaning, we reduce the FiO2. So once the FiO2 has been reduced to less than 0.5, we start reducing P high 2 centimeters of water every 2 to 6 hours. And when the P high has come down to less than 20 centimeters of water, that means that we assume that the plateau pressures are now less than 20 centimeters of water. We start increasing T high by 1 to 2 seconds. And once the P high, remember the range of P high is 3 to 8 seconds, right? So once the P high is less than 10 centimeter of water is considered weaning. And if the P high is 12 to 15 centimeters of water, you switch to conventional mode. So if the P high is more than 20 centimeters of water, you keep on increasing T high by 1 to 2 seconds. And once the P high comes down to less than 10 centimeters of water, you consider weaning. So if the P high remains 12 to 15 centimeters of water, switch to conventional mode. That means once you have weaned from 20 to 15 centimeters of water, what you can do is you can switch to pressure support for weaning and spontaneous breathing trials. Okay, so this is how you do. Okay, so once a P high is less than 20 centimeters of water, you start increasing T high. And once P high is less than 10 centimeters of water, you can extubate the patients. Or if the P high is in the range of 12 to 15 centimeters of water, you can switch to pressure support and then continue conventional weaning. Now, these are the advanced modes which are used for weaning, and weaning failure has been shown to be reduced with APRV. Now, coming to a very intelligent mode of ventilation, that is adaptive support ventilation. It comes very close to closed loop ventilation, which provides optimal breathing pattern based on minimal work of breathing. And more or less, it is easy to set because it has got only 3 parameters which are to be set. That is the percentage of minute volume, minute ventilation, that is P, and FIO. Okay, so we all know that in pressure control ventilation, control mechanical ventilation, SIMV, and pressure support ventilation, these are all the parameters that we have to set, right? So modes, these are the different modes which we defined. In this, we use the ASV mode. Now, for all these modes, we set a variety of parameters for CO2 elimination. That is tidal volume, we set the pressures, we set the inspiratory time, we set the expiratory time, we set the inspiratory pressures, we set the pressure support, we set the rate. That is for the minute ventilation to be achieved for CO2 elimination. As we all know, higher the minute ventilation, more the CO2 elimination. Now here what we said is the percentage of minute volume. That means what is a minute ventilation that is to be achieved by the ventilator. So this is based on the patient's ideal body weight, based on the equation body weight into 0.91 into height, body weight, that is 50 or 45.5, body 50 in case of males, 45.5 in females, plus 0.91 into height of the patient minus 152.4 centimeters. Okay, so from that formula, we derive the patient body weight and the minute ventilation at 10 ml per kg or 8 ml per kg. That is 8 to 10 ml per kg. That is the minute ventilation required. Okay. Now, if we set patient is not breathing at all, then we set it at 100% minute volume, so that the entire work is done by the adaptive support by the ventilator. And for oxygenation, as usual, as in other modes, we set the FiO2 and PEEP values. Now, this is the graph. Suppose there is a patient whose minute ventilation has been calculated to be 7.5 liters per minute. Now, ASV works on the basis of your respiratory rate and tidal volume combination. The same index that we use, Young's index or the RSVI index that we use for RR and VT. So if we see, here is the rate and here is the tidal volume that is to be achieved. Now, to achieve a minute volume of 7.5 liters per minute, we've got 3 or 4 combinations. One combination is 1500 ml into 5 breaths per minute, 150 ml into 50 breaths per minute, and 500 ml into 15 breaths per minute. All will deliver a minute ventilation of 7.5 liters per minute. So now, as you can see from this graph, which one is the best? These two are the extremes. Obviously, you won't be ventilating the patient with 50 breaths, neither would you be ventilating with a high tidal volume or a low rate. So what this mode does is that it plots a graph, and based on the lung compliance, the tidal volume and the rate that can be achieved, it provides the best ventilation strategy. So as to it creates a target that this is the target that has to be achieved based on this graph. Okay. The other thing is the RC time constant. This mode functions on the basis of RC time constant. That is, it reflects the speed by which the system changes its volume in response to a change in applied pressure. So this also takes into account the stiffness of the lungs, that is, and the airway resistance. So RC is defined as resistance into compliance, and this gives you a time constant. So it takes into account the resistance and the compliance, and at the same time takes into account the respiratory rate and tidal volume combination to achieve the breath strategy. So as we know, if you see here, this part of the graph calculates the RC inspiration, and the expiration is by RC expiration. Normal time constant RC expiration is 0.6 to 0.9 seconds when there's a normal compliance and resistance, or the order is reversed. So the normal value is 0.6 to 0.9 for the RC time, RC expiratory time constant. It is 0.6 to 0.9. Now, how does it do that? Basically, what we do is we describe the target minute volume. That is for CO2 elimination. Okay, this is the minute ventilation that we have to provide, and we set the higher limit of the peak pressure that the ventilator is allowed to give so as to achieve that particular target volume. Okay, so what the ventilator does is it gives 3 test breaths in which it calculates the inspiratory pressure, whether the patient is taking any breaths or not, and time for inspiration, and also collects data for RC expiration as we said above, compliance and resistance, spontaneous activity if there is any of the patient, and RR and VT. Okay, that is respiratory rate and VT. How much is the respiratory rate taken by the patient, and what is the tidal volume generated by the patients? And 3 test breaths are given on the basis of the ideal body weight and inspiration, F total, and P inspiration. So what it does is that it has, we have said this, it gives 3 breaths, it collates data breath by breath, and ASV algorithm calculates the optimal target respiratory rate and tidal volume based on Otis and Mead's equation. So that is what it does, that it calculates the optimal volume, and it adjusts mandatory rate and peak inspiratory pressure within the pressure limit defined by the user. So what it does is that, okay, the patient is not breathing, right? It will give 3 test breaths based on the target minute volume and ASV limit. It will calculate the compliance and resistance. It will see that the patient is not breathing. As for the previous example, it is 7.5 liters per minute has to be given. Now, we have seen that the ideal combination in that particular graph was 500 breaths and 500 ml in 15 times. That is 15 breaths per minute is the ideal combination that we have found out. So if the patient is not taking any breaths, it calculates optimal target RRVT, and it will deliver the 500 ml at 15 breaths per minute with the least pressure, and which gives the maximum compliance. So it can be any mode. You cannot decide the mode of the control breaths and the I ratio. It will again see whether there's any auto PEEP, whether the exhalation is complete or not, and then accordingly decide its own IE ratio. That is not to be decided. And if the patient is breathing spontaneously, then it will work as an SIMV or a pressure support depending on the patient effort and rate, and keeping RSBI within limits. So how does it define the limits? Okay, so as I said, it calculates the RC expiratory, and 0.6 to 0.9 seconds are the limits that we had shown here. 0.6 to 0.9 seconds is the goal, right? So if you see that if the cursor goes in this region, this will be dead space ventilation. If it goes into this region, it will be apnea. If it goes higher up, that might cause baro or volutrauma. If it goes here, that means exhalation is not being completed. So the idea is to choose the best strategy so that the VT and RR remains in this white circle, and every 3 to 4 breaths from the patient's data, the ventilation is altered so as to achieve this particular target, which is optimal for the patient. So that is how an ASV works. Now, while weaning, we gradually come down onto the minute ventilation support. As I said, when we say 100% or more than 100%, that means that the ventilator is providing all the work, nothing is done by the patient. As we decrease the pressure support while weaning, we decrease the minute volume gradually. Now, once we have oxygen at 40%, PEEP at 5 centimeters, and minute ventilation at 25%, that means only 25% of the work is done by the ventilator, rest 75% is being done by the patient. What we do is we see these parameters: oxygen, PEEP, minute volume, P inspiratory, RSBI, and percentage of spontaneous breaths. Now, these are the guidelines that they are. Now, if you see that all the parameters are within range of this, and we see that there's a square here and it falls, this is the patient's efforts, and this is the target to be achieved. Now, if we see that it falls very well in that white square or closer to the target, then a spontaneous breathing trial can be given and patient extubated. So that is how these AI tools can actually help in controlling ventilation as well as your weaning protocol. Now, a step further in adaptive support ventilation is IntelliVent ASV. Now, again, it is a closed loop ventilation. It is purely automatic. Now, in this, it decides on percentage minute volume also to reach target ATCO2 in passive patients, and it targets respiratory rate in spontaneously breathing patients. Now, in this, you don't have to do anything to be precise. All you have to do is set in the targets, you have to set in the patient's condition, and rest of the work is done absolutely by the ventilator. So it's almost like that Hero Honda ad, fill it, shut it, and forget it. So the main thing is that you feed in the condition to the ventilator, and rest of the things will be done by the ventilator. Although it doesn't translate like that practically, you have to monitor each and everything that you're doing. You just cannot leave everything to the ventilator to be taken care of. So again, as I said, it targets percentage minute volume in passive patients, that is those who are not having any respiratory efforts, or it targets respiratory rate in spontaneously breathing patients. And as earlier, it selects the RRVT combination according to the ASV algorithm. So what it does is, either in ASV, we have to set the minute ventilation. In this IntelliVent ASV, based on the CO2 and the respiratory rate and defined target values, the percentage minute volume will be altered by the ventilator itself. Similarly, the PEEP and oxygen targets, either we can set them or it can be altered based on the SpO2 and defined target volumes values by the ventilator itself, applying ARDNS table and the open lung approach and the user set limits. So these are the three algorithms that it encompasses to set. That means that it takes input from the ASV algorithm, that is the patient's compliance and resistance, and CO2 we were seeing an altering. Here the CO2 is fed into the ventilator. The ventilator itself decides on the basis of that whether the minute volume needs to be altered or not, and the SpO2 signal which is fed to the ventilator will help you decide how much PEEP and oxygen. PEEP again on the basics of the mechanics, and percentage oxygen defined on the basis of the SpO2 using ARDS net, open lung approach, or the settings defined by the user. So again, we set the patient type, gender, and height. Now remember, in all these newer modes, it is very important to type in this. If you don't put in the patient type, gender, and height in the previous ones, and the patient type. Patient type means neonate, pediatric, or adult. So these three are very important whenever you are using these control modes. So these information has to be fed in before you connect, before you choose these modes. Now, apart from that, there are three conditions which are preset into this IntelliVent ASV mode. That is ARDS, brain injury, or chronic hypercapnia. So these are the three conditions. Out of these, you select one of the three conditions so that it can apply optimal algorithm. Then we set the CO2 target range and the ASV limit, the high pressure limit. As before, it gets the CO2 value, it calculates the the time constant, RC time constant, and the spontaneous tidal volume and the rate, if any, by the patient. It automatically adapts percentage of minute volume based on these parameters to achieve a target EtCO2 or target respiratory rate when the patient is breathing spontaneously. In spontaneously breathing patient, okay, it will target the respiratory rate so that the support is maximal, such that EtCO2 is within the user-defined target plus minus 3%, 3 mmHg. Okay, so what it does is it controls the ventilation, which is passive. So what it does is that we have defined the PET CO2. So if you see here, the PET CO2 is up above the upper limit. User defined target limits are 41 to 47. Okay, sorry, 35 to 41 and 36 to 43. So it is higher. So what it will do? It will increase the minute ventilation on its own. Limits for percentage minute ventilation are 70 to 200%. So it can increase or decrease depending on the end tidal carbon dioxide. Similarly, if it is less, the EtCO2 is below the lower limit, user defined limits, then what we do is, what it does is that it will decrease the percentage minute volume breath by breath so that the patient does not hyperventilate. Okay. Now, oxygen controller, as we have said, that these are the things that is set by the clinician. Patient condition we have already specified. We set the SpO2 target range. We set the PEEP limit. Okay, this is the minimum PEEP that you can give. This is the maximum PEEP that you can give. And what is the minimum FiO2 that you can give? Okay, and then from the patient, it gathers the SpO2 and the lung compliance data. On the basis of that, it automatically adapts percentage oxygen and PEEP level, as I said, depending on the ARDSNet protocol, open lens approach. Okay, and we have defined the target SpO2 lower limit and the upper limit. So if you see here, we have set the oxygen at 30%, SpO2 is 97, HLI is 13, that is FiO2 by PEEP, and here we get it as 7. So this is the optimal, and this is where the patient lies, and that is how it controls the oxygenation. Okay, so here we set the PEEP levels. If the saturation is okay, no change. If the saturation is low, it will increase the PEEP and FiO2 depending on the user limits that you have set and depending on the ARDSNet protocol. Okay, so that is how you set it. Okay, now this is the screen how we set it. So we can set the percentage minute ventilation as automatic or manual. PEEP or CPAP, again automatic. Oxygen, again we have the option of overriding it. Patient condition, ARDS, chronic hypercapnia or brain injury, right? And if we want to control the ventilation, we keep the weaning option as disabled. PEEP limit, we set the lower limit or upper limit on our own, or we decide on the HLI and auto recruitment if required. That is FiO2 by PEEP and PEEP by SpO2. That is how the oxygenation is controlled, and on the basis of your peak pressures and the CO2 values, your minute ventilation is set. Okay, So that is all you have to set, and rest of the work is done by the IntelliVent itself. Now, for weaning these patients, there's a screening phase wherein the patient, the ventilator first screens whether the patient is weanable or not, then puts the patient into spontaneous mode. It goes into the quick wean mode, and if the conditions are fulfilled, that is that oxygen, PEEP, rapid shallow breathing index, the tidal volume to idle body weight, whether the tidal volume generated by the patient is adequate or not, pressure support is low or not, and the spontaneous rate is adequate or not. A spontaneous breathing trial may be started by the user, or as you saw in the previous screen, we can give an automatic, or whenever the ventilator feels that the patient is weanable, it will start a quick wean and a spontaneous breathing trial. And if everything turns to green, that means that all is fine and patient can be disconnected from the ventilator. So if you see, everything has been taken over by the ventilator only. All you have to do is observe and correlate clinically whether whatever the ventilator is saying is correct or not. Do not entirely go on to the what the ventilator is saying, but you have to observe the patient as well. Remember, these are not a replacement for you. A machine can work only what you feed into it. So remember, you have to take into account what the machine is doing and how the machine is behaving, and whether you can trust the machine or not. Okay, so that is one of the most important things that you have to take care of. Please remember, this is not a substitute that you put the patient on ventilator and you forget it and the ventilator will do the work for you. You'll still have to monitor the ventilator. Okay, so these were the modes where you can use both the control mode as well as the spontaneous modes, or a combination of two. Now coming to the weaning modes. So traditionally, we have seen that pressure support is the most common mode used, and in which we have to set that we have to set the pressure, and the problem is that the volume keeps on changing depending on the lung compliance and resistance. Now, this volume support is again a closed loop ventilation for spontaneously breathing patients. It adjusts the pressure support on its own to achieve a particular set tidal volume. That means that if the patient is generating a high tidal volume, it will automatically reduce the assistance. And if the patient is generating low tidal volume, it will automatically increase the support by the ventilator so as to give the best comfort to the patients. Now, what we set is the FiO2, the target tidal volume, PEEP, trigger, and slow. So all it does is that, and obviously the alarms for that particular patient. So if we see that the patient has generated an inspiratory flow, it sees the pressure support level patient can expire, and if the requirement is more, it will increase the pressure support so as to meet the tidal volume. Okay, and I ratio, if the patient goes into apnea, it will activate the apnea ventilation. Now remember, for all the spontaneous modes, purely spontaneous modes, it is very important that you set the apnea backup rates and settings properly. So this was the volume support, almost same as pressure support that we use day in and day out. The only thing is that it is a closed loop system. Now, another important mode is the proportional assist ventilation. Again, it's a closed loop ventilation. So we all know that the pressure that is given by the ventilator translates to the volume that is administered. So what it does is that it calculates on the basis of this equation how much is the support to be given by the ventilator. So P muscle is the patient's effort, P applied is the ventilatory effort, which is equal to the volume, that is the tidal volume, based into elastance, and flow into a resistance plus P pi. So basically, the tidal volume into elastance and flow into resistance gives you P muscle plus P application, P applied. So basically, this is what is to be calculated. So it depends on the spontaneous breaths, plus it also takes into account neuromuscular drive. So it gives, it gathers data over 4 to 10 breaths, gives a pause of 300 milliseconds, and then applies this equation to decide how much of pressure is to be applied. So what we do is we set the proportion of assistance to 10 to 90%. We monitor work of breathing and keep muscle activity to 5 to 10 centimeters of water and measures the delta P, that is P peak minus PEEP. So based on this graph, on this table particularly, what we do is we see the delta P, that is P peak minus PEEP, or the driving pressure. And the idea is to keep the P muscle between 5 to 10 so as to decrease the work of breathing by the patient. This is the minimum work of breathing. So our idea is to target this particular wide band. So suppose if my P peak delta P is 15 and I want to provide comfort to the patient. So what I do is I give the percentage of assistance. I start at this one. This is the wide maximum. So if I go here, that means I have to give 75. If I go low, P muscle, if I have to offload the muscles, that means I have to provide the maximal assistance. As I said, P muscle, 5 to 10 centimeters of water. So 5 here. So I start with 80% and then gradually decrease it to 65%. As the delta P decreases, my support will go down. So that is how I decide on what is the proportional access that I have to keep. Again, a very useful tool for your weaning. Excuse me. Okay. The other one is neurally adjusted ventilator assist, or NAVA. Now, this is the only mode which has shown a mortality benefit over the conventional modes. All the other modes, they have shown better oxygenation, reduced mechanical ventilatory days, reduced stay in the ICU, but the mortality benefit has been shown only by the NAVA, not very commonly used, and that too in infants and neonates. So it is basically a pressure assist during inspiration. What it does is it measures the electrical activity of the diaphragm. So remember, it is not a pneumatic cycling or triggering. It is based on the electrical impulse generated by the contraction of the diaphragm. Now, as we know that if the contraction is more, the current generated will be more, and if the contraction is less, the current generated will be less. On the basis of that, it will control the amount and profile of support delivery. So it measures the electric amplitude at crural portion of diaphragm via a nasogastric feeding tube, which has got 8 bipolar electrode at its distal end. Now, this tube can be used as a normal feeding tube as well, and it is connected to the ventilator, which senses the electrical activity generated by the diaphragm. So the peak inspiration pressure is equal to the NAVA level that we define, the electrical amplitude maximum and minimum, and peak. So how does it work is, okay, so basically earlier the mode was PRVC. Okay, P peak was 26 and PEEP was, we set the limits, RR and minute ventilation. We start with a basic NAVA level of 2 centimeters, PEEP of 5, oxygen concentration as per this, and trigger EDI. Trigger EDI is kept at the minimum. Okay, and then pressure support. And when do we, at what percent do we cycle the inspiration, and pressure support above PEEP? How much is to be given? So we check the EDI first. We check the EDI peak. If it is high, that means if the EDI is high, that means that the muscles are working and it is under supported. So you increase the NAVA level. If it is low, that means there is a poor respiratory device, provide adequate backup support, or if it is over supported, you decrease the NAVA level. If ED minimum is more than 5 microvolts, then FiO2 is high, increase PEEP. If patient is clinical stable, you don't change anything. So basically you see the basic NAVA level and you monitor the EDI. On the basis of that, when the NAVA levels come down to less than 1, then you start weaning, right? So with this two trigger EDI is 0.5, that is the minimum. You assume that the peak estimated will be 24 centimeters of water and you monitor the rate and everything. So that is how you do it with NAVA. Another important mode now that has come up is SmartCare or pressure support. Another thing which is used for weaning. It is used for automated weaning in patients more than 15 kgs, mainly in adults. It uses the rate, tidal volume, and ATCO2. It takes around 5 minutes to adapt and classifies the breathing pattern into 8 diagnoses, decreases the pressure support gradually, and provides a spontaneous breathing trial on its own. So based on this, basically what it does is it estimates the tidal volume every 10 seconds, ATCO2 every 10 seconds, spontaneous rate every 10 seconds, body weight we have fed in initially, COPD, if the patient is COPD or has a neurological disorder, then again that has to be fed initially, and every 2 to 5 minutes. These are the 8 diagnoses in which the SmartCare will keep your patient in. That is normal ventilation, severe tachypnea, insufficient ventilation, hypoventilation, central hypoventilation, hyperventilation, unexplained hyperventilation, or tachypnea. So basically, on the basis of that, it will either increase or decrease the pressure support. And when there is normal ventilation, when the parameters are down, it will give you an alarm. Okay, now the patient is weanable and you can disconnect the ventilator. So this is again a useful tool based on which you can decide if the patient goes in for hyperventilation or insufficient ventilation. Again, it will give an alarm. You have to change the mode to a control mode maybe. So that is how these tools can be used for better control of ventilation and your successful weaning. Now, we all know that in case of cardiac arrest, we know that when naturally in ICU, the patient will be on a definitive, will have a definitive airway in situ. So we know that it has to be shifted to volume assist control mode with a trigger and alarms are to be turned off. Why? Because obviously the peak pressures will be high. The trigger, when you're compressing, that will act as a trigger. So the ventilator will sense it as a breath and keep on ventilating the patient, will cause asynchrony. And we know that whenever the chest compressions are on, we have to deliver 1 breath every 6 seconds, irrespective of whatever is going on, with an FiO2 of 1 till there is ROSC. So in this case, all you have to do is just press CPRV mode, and this is taken care of. The settings automatically change to FiO2 of 1, PEEP of 0, P peak of maximum of 60 centimeters of water. However, the tidal volume and rate are to be set by the operator. So we set the tidal volume and rate as 10, and that is all you have to do, and it will take care of your ventilation during CPR. So thank you. That was my presentation on newer modes of ventilation, advanced and newer modes of ventilation. I'm sorry I went a bit fast, but I'm assuming that you all know the basics of the basic modes of ventilation, and these are just an add-on. So I think we'll take the questions at the end of the session. So over to Clarnet, please. Thank you.
Thank you so much, Doctor, for this insightful lecture. I request all the participating doctors to raise questions if you have any. Now we have got another very eminent speaker doctor with us today. He's none other than Professor Nitin Hairan, sir. He's a MD Professor Anesthesia, Lady Hardinge Medical College, New Delhi. It is an honor, sir, to have you with us today, along with Dr. Nishant Kumar sir as well. I'm sure the doctors will be enriched with your lecture as well. Your topic will be role of cardiopulmonary biomarkers. So I would like to hand over the session to you, sir. Please take it over. Over to you, sir.
Thank you, Anamika. Basically, I will be discussing about the role of the cardiopulmonary biomarkers as a diagnostic aid whenever we are encountering a patient who is dyspneic, a dyspneic parturient who is um, uh, being evaluated. So we so now and then I think everybody might have received a call in ICU or in OT to evaluate a dyspneic patient who is being uh, either posted for surgery or is just for resuscitation purposes. So whenever we encounter this type of patients, the first and foremost important thing is to understand about what the physiological changes that may lead a patient who is having dyspnea. So if we see the cardiovascular changes throughout the pregnancy from pre-gestation to first to second and third trimester and till delivery, we see an increase in the cardiac output from first trimester, and that that is at the peak at the delivery. Similarly, the blood pressure and the heart rate is also high. Blood pressure and the systemic vascular resistance remains more or less normal or in a lower range during the all the trimester of the pregnancy. When we see the pulmonary system, the lungs, so there are a lot of anatomical and the physiological changes because of the gravid uterus as well as the hormonal changes that are there. So there is increased respiratory drive resulting in reduced PSU2 mainly because of the increase in the progesterone level. There is an increased minimal change in the TLC, increase in the tidal volume, reduction in the FRC because of the reduced expiratory reserve volume. And there are changes in the airway also. So these are the important changes that are usually normal physiological changes. So when we say dyspnea in pregnancy, so we should always our first step in assessment should be to differentiate the physiological and the pathological causes of dyspnea. So physiological dyspnea of pregnancy is a well-known entity, and it is usually there in most of the patients, and we should be able to differentiate between the physiological and the pathological causes of dyspnea. Of the various pathological causes that I have listed here, the most important causes that you should be wary of are the anemia, preeclampsia, peripartum cardiomyopathy, embolisms, pneumonia or ARDS, asthma exacerbation, if patient is having asthma already, and ischemic heart disease. So when we see a patient when we evaluate a patient who is a dyspneic and is gravida, so first step that I already mentioned is to differentiate between physiological and pathological dyspnea. So when we see the physiological dyspnea, mechanism is usually it's unclear. It is basically because of the body habitus or progesterone-induced hyperventilation, the physiological anemia of pregnancy, or increase in the pulmonary blood flow. But in pathological, usually there is some other etiology is present. The physiological dyspnea, the onset is gradual, but in pathological, it is sudden onset of dyspnea. The timing of origin of or starting of the dyspnea is usually first and second trimester in the physiological dyspnea, and the pathological usually start either at second or in the third trimester, or most commonly at the time of labor. Progression, usually it remains stable. Physiological dyspnea remains stable, and the pathological dyspnea usually worsens near the term. When we say about the positioning, the physiological is worst in the sitting position, and the pathological are basically worse in the supine. So the association with exercise, so these physiological are not associated with exercises, and the pathological dyspnea patients may not be able to perform even normal daily activities. There are no physical findings in the physiological dyspnea, and there are some findings that we need to evaluate for finding the exact cause of the pathological dyspnea. So initially, the gamut of investigations can be done from hemoglobin hematocrit for diagnosing anemia as a cause of dyspnea, for metabolic causes in glucose, urea, nitrogen, electrolytes, and other, maybe to rule out any metabolic cause of dyspnea. Thyroid functions basically to diagnose hyper and hypothyroidism. The spirometries, SpO2, radiograph, and ECG, they are all basic investigations when we encounter the patient with dyspnea gravida. But even after these all tests, it's not always possible to differentiate between the physiological and the pathological. So suppose this is the normal presentation we usually encounter. At 39 weeks, G1P1, gravida 1 para 1 with a history of gestational diabetes presented to casualty with nausea, diarrhea, and dyspnea. On examination, there were bilateral crepitations. Saturation was 80%. BP was a little bit higher at 168/98. Mild renal and liver dysfunctions were present on investigations. Patient was required to be shifted to OT for emergency cesarean delivery. Post cesarean, patient was shifted to ICU for further management. So the vitals remain stable in the ICU. So seeing this picture, we think that patient is having bilateral crepitation, that is pulmonary edema and desaturation. So we usually take the next level of investigation, that is the NT-proBNP and the troponin I, high sensitivity troponin I, and it was elevated. So elevated to a moderate level, as well as HSTNI also was within normal limits. So considering these values, we think it may be a failure. So differential diagnosis, it may be a failure. It may be patients having ischemic heart disease, severe preeclampsia, embolism, what all can be thought of. So, so before jumping on the diagnosis, we should understand the way these cardiobiomarkers behave during pregnancy. So the way they behave, they help in distinguishing the normal pregnancy from that with early cardiovascular disease. So the most commonly that we do, the investigations that are done are either BNP or NT-proBNP, or that denotes the ventricular release of the peptides in the response to stress on the myocardium, as well as atrial natriuretic peptide, mid-regional fragment of prohormone, and adenomedullin. So when we talk about the normal pregnancy, we know that there is an increase in the plasma volume, and also there is a mild chamber dilatation, the mild cardiac chamber dilatation. So the normal value usually doubles during pregnancy. So the levels of BNP as well as pro-BNP are on remains around, they become around double during the pregnancy, but they the upper reference limit for BNP is around 50 picogram per ml with no significant trimester related differences. The upper limit of pro-BNP remains at around 200 picogram in first and second trimester, and 150 picogram per ml in third and postpartum period. So one important thing is the level remains stable throughout the trimester if there is no cardiac disease. So that is one important thing to understand when we get the cardiac biomarkers. Another important thing, when we the most commonly done is BNP and NT-proBNP. NT-proBNP is a robust marker during pregnancy, as that the BNP is usually degraded by neprilysin that is being released by the placenta into the maternal circulation. That is why the sensitivity of the BNP is reduced, and NT-proBNP remains the marker of choice during pregnancy. So when there are low values of BNP and NT-proBNP, they exclude the diagnosis of heart failure. But converse is not true. Some patients may have more than 100 BNP or more than 300 proBNP, but they do not have any, they have normal LV functions, and dimensions. So BNP rose in late pregnancy and early postpartum period, even in the absence of clinical or echocardiographic cardiovascular function. So there is a gray area between 300 to 450 or 100 to 500. There is a gray area which exists in the pregnancy. So less than 100, we exclude the diagnosis of heart failure, and more than 500 confirms the diagnosis of heart failure. But there is a gray area between 100 to 500. So, increase in the occurs usually in the patient with pre-existing heart disease more than 500. And the positive predictive value of natriuretic peptides for heart failure is generally lower. So there are the gray area is basically between 100 to 400. So patients who are having severe PIH, they may lie in the gray area. The patients who are having renal dysfunction, they lie in the gray area. And patient with high BMI also lies in this gray area. So in these patients, the values between 100 and 400 doesn't diagnose the failure in these patients. So the level of BNP is, as in normal patients, also prognosticate. So the higher the values, more severe is the failure, and the titration of therapy can be guided with these values also. The titration of the heart failure therapy usodiuretic can be modified by judging the decrease in the wet BNP levels during the treatment. So these natriuretic peptide levels return to normal within 6 to 12 weeks postpartum. So if a patient is having increase in these values even after the 6 to 12 weeks of postpartum, you should always further evaluate these patients. And so in the preeclampsia patients, they remain further high till 3 to 6 months in preeclampsia. So serial assessments of these peptides may help in identifying at-risk patients. So we already have mentioned that there is increase in the natriuretic peptide concentration among pregnancies complicated by preeclampsia than among normotensive pregnancies, but they don't rise to a level that is diagnostic of failure. The level of NT-proBNP was greater in those with early and severe preeclampsia. The role of so this was a very nice systemic review that was published in 2021. The role of NT-proBNP is prognostic biomarkers for preeclamptic complications, and they found that the level of NT-proBNP was greater in those with early and severe preeclamptic patients. So this was about the natriuretic peptides. The mid-regional Pro-A natriuretic peptide, or ANP, that is usually called, comparable to BNP in terms of diagnosis of acute heart failure. Though the levels more than 120 picomole per is equivalent to BNP at 100 picogram ml cutoff. So basically, it is important that the dose in patients. So it is not affected by the gray zone area. So combining the biomarkers increase the diagnostic accuracy in areas where BNP and NT-proBNP are less informative. So you can combine the two biomarkers that may predict. They have a more positive predictive value than a single biomarker alone. So there are a lot of new novel biomarkers that are being explored. Basically, we know that both preeclampsia and the peripartum cardiomyopathy, there is an imbalance between the pro-angiogenic factor and the anti-angiogenic factors. So the relaxin, the prolactin, the SFLT1 were all elevated in the early postpartum in women presenting with PPCM and rapidly declined post delivery. So research is still on to determine whether which is a better biomarker in the identification of the patient who are having PPC. So another I already mentioned about prolactin, then cathepsin, ADMA. These are all important biomarkers that are being now studied for probable association with the high incidence of PPCM. So this was a research article that was published in 2020 in the peripartum cardiomyopathy plasminogen activator inhibitor. It is a potential new biomarker with controversial role. So most of these names that I've already mentioned have controversial roles, and they still needs to be evaluated further to actually reach on to the diagnosis. So regarding the preeclampsia, we have this TLR4 involved in non-specific immunity that bridges between the non-specific and specific immunity. So it is expressed in the placental tissue and serum of preeclamptic patients, and the levels were higher in these patients. Apart from this, the placental growth factor and soluble FMS like tyrosine kinase that already mentioned for PPCM and other factors, they may be implicated in the diagnosis of preeclampsia. So these are the novel biomarkers on which the studies are still going on. Then now we have seen about the PPCM and the preeclampsia. So these are the most commonly things that we usually think of when we evaluate a patient who is dyspneic. Another important thing is pregnancy-associated myocardial infarction, or PAMI, that is usually called in short form. So ischemic event may also be a cause of dyspnea. In pregnancy, troponin and the CK levels remain below upper limit of normal throughout the pregnancy. So like in peptides, these levels are also increased to around 2 folds to the upper value. And the mean concentration of myoglobin, CK and CKMB, creatine kinase and creatine CKMB, increase nearly twofold of the upper limit of normal 30 minutes post-delivery. That is the time when it is the highest. Myoglobin normally is normalized by 12 hours post-delivery, while both CK and CKMB remains at peak level until 24 hours postpartum. Troponin I is increased during early postpartum period, with peak values obtained 24 hours post-delivery. So this is the normal physiological, the normal the values that are changed in the pregnancy, that are the markers that are required for evaluation of myocardial ischemia. Peak troponin I values during delivery and early postpartum still remain below a value of 0.15 nanogram per ml for. So if we say the high sensitive troponin I is more sensitive than all the conventional assays that we have mentioned in the last slide, mild elevations of hard biomarkers are prevalent, but existing cutoff values for ruling out MI, that is less than 14, are applicable during pregnancy. So there is a difference in diagnosis of failure and ischemia. So HS high sensitivity troponin I less than 14 as in normal patients is also applicable in pregnancy. So increase accuracy of MI diagnosis, especially at 1 hour, with the help of high sensitivity troponin I. So when we see the use of cardiac troponin used during pregnancy, in normal pregnancy, if there is an increase in the value, you should always prompt for investigation of potential. But a patient who is preeclamptic, obtain measurement of troponin in patient with signs and symptoms of ischemia. So until unless we have signs and symptoms of ischemia, there is no indication for getting routine measurement of any cardiac biomarker. So no data to support routine measurement of troponin in the absence of clinical concerns of ischemia. It is not required until unless you have some signs or symptoms of ischemia. So coming back to our the original patient. So if you remember, the troponin proBNP level was around 444, and the troponin I, HSTNI, was less than 12. So then transthoracic echocardiography was done. The ejection fraction was determined to be around 66% with the normal RV function, left ventricular volume was mildly thickened, LA volume were normal, there was mild MR and TR. So considering the values that we have already seen and we have already discussed, so the most probable diagnosis would not be cardiac failure, it would have been severe preeclampsia. So this is the role of biomarkers in actually differentiating the most probable condition. So until unless we get this TTE, we are dependent on the surrogate investigations. So another important pathology that may present as dyspnea in pregnancy is the pulmonary embolism. And rapid and accurate diagnosis is very essential because of the treatment that is of help is anticoagulation and need for thrombolysis. But for diagnosis, sensitive, high sensitivity D-dimer, BNP troponin I. So they may give insight regarding initial diagnosis. So D-dimer is detectable at levels greater than 500 nanogram in nearly all patients with pulmonary embolism. But in the case of pregnancy in which it is already high, a D-dimer cutoff value of 800 nanograms ensures high sensitivity and increases specificity compared to conventional threshold of 500 nanogram per ml. But only the values of elevated D-dimer is insufficient to establish diagnosis of pulmonary embolism. They don't have a very, they have a negative predictive value around 97% to 100%. They have a very good negative predictive value, but the American Thoracic Society does not recommend D-dimer to rule out pulmonary embolism. So there are a large number of criteria like Wells criteria, Geneva criteria, but most commonly used is the Years algorithm. So if there is a clinical sign of deep vein thrombosis, hemoptysis, and pulmonary embolism as the most likely diagnosis, and measured D-dimer level. The combination of a clinical signs and the D-dimer levels usually indicate the pulmonary embolism. So pulmonary embolism was ruled out if none of the three criteria were met and D-dimer level was less than 1000 nanogram per. Or if one or more of the three criteria were met, D-dimer level was less than 500 nanogram per ml. So this is basically the diagnosis. So if there are one criteria is present and the D-dimer levels are high, so it goes in the favor of the diagnosis of pulmonary embolism. Another important thing is amniotic fluid embolism that is usually there at the last third trimester usually. So here, if we suspect an amniotic fluid embolism, biomarkers that may be of help are the serum tryptase levels. There are usually around 7 to 10 times higher in patients who are having a very lethal amniotic fluid embolism. As well as lower complements levels like C3 and C4, suggesting there is usually a complement activation during the embolism. CL troponin is a component of meconium and mucin derived from amniotic fluid. It is a very sensitive indicator or a biomarker for diagnosis of amniotic fluid embolism. Gradually it is coming up as a point of care test in the laboratories for the diagnosis of amniotic fluid embolism. So CLL in maternal serum in patients suspected is a direct diagnostic test. So there are a number of biomarkers and tests proposed for AFE, amniotic fluid embolism, and the most commonly we use are the tryptase and the CLL-T9. So a level more than 47 is considered abnormal, and AFE cases around is considered to be diagnostic. Another differential diagnosis that we already mentioned is the inflammatory or the patient suffering from pneumonia or pneumonitis or some lung pathology, some lung infection that may lead to dyspnea. So diagnosis and management of patient with dyspnea can be incredibly challenging if pneumonia is present. So So there is very low sensitivity and specificity of clinical signs and symptoms, especially of X-ray, and to differentiate between cardiac and non-cardiac dyspnea. So that is why we usually go to our old age biomarker, that is procalcitonin. So it is usually elevated in gram-positive as well as gram-negative bacterial infection, but it is usually attenuated in the viral infection. So it has to be you have to be very careful in evaluating the values of the procalcitonin. So another important biomarkers that can be help in diagnosis of the inflammatory as the HSCR or celiac. But nowadays many patients come with viral pneumonia also. So for viral pneumonia, myxovirus resistance protein A or MXA and a ratio of MXA with CRP has been suggested as a diagnostic tool for evaluating the viral pneumonitis. Myxovirus resistance protein is an intracellular blood protein that mediates cellular resistance against a wide range of viruses. It is elevated in most acute active viral infections. And compo test there are available in commercially. They help in assisting the diagnosis of viral and bacterial infections by mostly differentiating between viral and bacterial infections. Thank you.
Thank you so much, sir. Thank you so much, both the doctors who have given this wonderful deliberation. Sir, with all of your permission, can I take questions from the audience?
Yeah, sure.
Okay. As we have received a few questions, so I'm addressing one by one. So first question has come from Dr. Khemani. He wants, I mean, I don't know he or she, Dr. Khemani is written. What is the most sensitive biomarker for heart failure?
So already mentioned NT-proBNP in pregnancy. I've already mentioned NT-proBNP in pregnancy.
Okay, sir. Okay, going forward to next question. What is the primary principle of ventilation?
See, the primary principle of ventilation is that you have to substitute the normal breathing pattern. The thing is that we have the negative and the positive ventilation. The normal physiology is a negative ventilation. So the primary principle is that you have to provide oxygen and take out carbon dioxide. So however means by you do it, whether it is by negative pressure, that is the normal, you take the diaphragm down so that the air comes in and fills your lungs and the expiration is passive, or you inflate the lungs by giving positive pressure. Ultimately, the aim is to provide oxygen and take out carbon dioxide. That is the basic principle.
Thank you so much, sir. The next question is BiPAP versus CPAP. Which one is more effective?
It will depend on the condition of the patient. BiPAP, now again, whether you're referring to biphasic or bilevel, if you're comparing CPAP and BiPAP, now this is bi-level that I'm assuming the NIV that you're talking of. It'll depend on the patient's condition. CPAP is a continuous pressure that you apply both during the inspiratory as well as the expiratory phases, whereas bi-level, that means that the difference between the inspiratory and the expiratory phase, and it'll depend on the underlying patient condition. So I cannot say that one is better than the other.
Thank you so much, sir. The next question is, what is the most specific cardiac biomarker?
Already answered.
Sir, what is the most specific cardiac biomarker?
Specific in pregnancy remains NT-proBNP.
Okay, sir. The next question is AVM mode of ventilation. That's it. It's written like this.
So I assume that you're referring to the AC mode, because as I said that you have to understand what is the underlying mode rather than the nomenclature. So if you can clarify, I can clarify later. As I've told you, each manufacturer will have a different name for the same mode. So if it is ASV, I've already talked about ASV. AVM, now if you can give me the full form, probably, and the manufacturer, I can probably search for it, what exactly it means.
Okay, sir. Nothing is written as such. If the doctor, Dr. Kailash, this question has come from him. If you are listening, please let me know. I'll definitely address the same to
But
the
I think
doctor.
AVM most likely means adaptive ventilation mode. So it is the same as ASV. That is what I'm presuming. So I've already talked about ASV mode in my presentation.
Next question is, what are the 4 biomarkers for detecting cardiac damage?
So, cardiac damage related to ischemia remains different. Cardiac damage related to failure are different. So, question is not clear basically, but for stretch-induced biomarkers remains again that proBNP, BNP, ethyl natriuretic peptide, and for ischemic remains the the troponin I and the CPKMB and myoglobin. So they are they are not, we can say, just 4 or 5, or it depends on the pathology that have released the biomarkers in the circulation. So I think
Okay, sir. Thank you so much. The next question is, what bacteria causes VAP?
So PAP is basically multifactorial. Now there is MRSA, which is prevalent in the West. It is gram-negative in our country, and most common are Klebsiella, Pseudomonas, and Acinetobacter. So it will depend on the flora of that particular ICU. But yes, it is gram-negative in India most commonly, and MRSA in the West.
Okay, sir. Sir, we have received a few thank you note as well from the doctors. Thank you, doctor, for this wonderful presentation. Week Learned has received few recording requests also from the doctors. They have asked for the session recording as well. So your conference has been a great success, sir. I hope to continue conducting session with you in near future as well. I thank you, both of you, from the entire Learned team, sir. With all of your permission, can I sign off from today's session, sir?
I think if there's no questions, we can.
Yes, sir. We already have, and there are a few questions which you have already covered basically. That's why I didn't address it.
thank you.
Thank you.
Thank you so much, sir. Have a great day. Stay healthy.